reporter. Shirley needs no introduction to this crowd, but just kind of briefly, Dr. Krisztian Magori got his PhD at Utrecht University in Budapest, and then came to the States for postdocs at North Carolina State and the legendary Odum School of Ecology at University of Georgia, and then at Auburn University as well. He has been with us here as our disease ecologist and biostatistician since 2014. And something you may not know about Krisztian is that he is super active on social media. So if you are excited about what you learned today and want to learn more, in addition to getting in touch with Krisztian, you can also check out the Bug Bitten blog, which Krisztian is one of the founding editors. And you can also follow Krisztian on Twitter at #BiteOfTheMosquito. And with that, today you're going to be learning about COVID Adapt, otherwise known as what Krisztian was doing during COVID lockdown.
Thank you. Okay, thank you everybody for coming. And I think it's better inside now than outside. So thanks for sticking around. And really today, I just want to show you what I was doing in the last couple of years, kind of as if I'm showing it to my friends. And I could go around and sit down with everybody for an hour and show you what I have, and that would take a lot of time. So I was thinking it's better if I just bring everyone together and I can just show it to everyone. So what I was doing for fun during lockdown, which my wife reminded me this morning, that sounds really nerdy, but that's what I was doing. Okay, does this not work now? Maybe. It's okay. Maybe I broke it. It's okay. I have the arrow. No, it's actually maybe the slide. No, okay. This now works. Okay, now it works. Okay, thank you. Okay, so first of all, I want to start with acknowledgements. And my title slide said I was doing it, but it wasn't me really, or at least partly me. I had a group of students at Eastern, as well as some faculty who were helping me with this project and are still helping me. And I even had a group of students at Whitworth in computer science who is helping me to do this thing that you'll see. And so first of all, what am I not going to talk about? We had way too many talks about SARS-CoV-2 and the virology and all of that stuff. I'm not going to talk about that. That's all known. I'm also not going to give you a history of the COVID-19 pandemic. We all know what happened and all of that. This talk is not about that, although I will mention brief details. And I'm not going to give you predictions for the future. If one thing we learned over the last 2 years, we should just not try to predict what's going to happen, because we were wrong every single step of the way. What I am going to talk about is different approaches to model respiratory disease transmission on a university campus or any large facility where there's buildings and people. And COVID Adapt, the model that I and my students developed in my lab, and then how this model could be used and expanded in the future, especially in terms of behavior. So this is also me wanting feedback. You know how easy it is to get tunnel vision when you work on a project. You're thinking, oh, this is great and I love it. And so I don't see the what is not great or what could be better. Or so I need all of those things, and also ideas for what else I could do. What are the potentials? So I'm sort of looking for feedback here. Okay, so before we get to COVID, I don't know how many of you were around in 2016, 2017. We had a giant mumps outbreak in Spokane City, in the school specifically. We had 330 something students or people who got sick with mumps, and it was a big controversy. And partly it was because there were people with exemptions from the MMR vaccination, students who had exemptions. And then the health department decided that those unvaccinated students who had exemptions, they had to stay out of school because there were mumps cases in the schools. And some of those had to be for months, like it was a big deal. And so there was a lot of controversy. I was working at the time with David Guyan. Some of the faculty might remember him. He was a McNair scholar. He went on to get an NSF GRFP and as a PhD student later on. But with him, we investigated the impact of unvaccinated students returning to schools before their quarantine period would elapse, because there was such a request from the parents that the health department should do that. And what that would mean, we basically found that it would lengthen the outbreak because students would come back and sort of reignite the outbreak in the schools. So I'm just showing you that because this was my first sort of foray into trying to model this sort of building-based transmission with something that's easily transmissible. But there we were modeling a single school. We weren't separating into different classrooms and anything like that. It was very simple. But I did go to the Spokane Board of Health and gave a public comment saying at their meeting, talking about how they shouldn't relax the quarantine period because then that's what's going to happen. Here at Eastern, we have been doing infectious disease modeling, many of us in our classes, right? I know Justin in ecology does a little unit. I do something in my disease ecology capstone just in the beginning. We're using simple deterministic models, just like an SIR model, like susceptible, infectious, recovered type stuff. And just sort of assuming that campus is a giant petri dish and everybody just walks around and everybody meets with everybody. Very simplistic stuff. I know in my class, we estimate the proportion that would need it to be vaccinated to not have, say, a measles outbreak on campus. Like just simple stuff. But that's too simple for any operational purposes. So then the COVID-19 pandemic hit, right? So I remember I first saw an initial report on New Year's Day on this listserv that I am subscribed to about some strange disease outbreak in Wuhan. And I've seen these before and I wasn't particularly concerned, but I took notice. I even in January told students not to worry too much about it. And I was really delusional up until the end of February. I was thinking China will just contain this and it's not gonna get out and it's gonna be fine. And of course, that's not what happened. So as a disease ecologist, this is your worst nightmare, right? Like this is what you train for, like a global pandemic where there's no disease, no pharmaceutical interventions, and everything just shuts down and it's bad. It's also the most fascinating time to live as a disease ecologist, but that's, that's very contradictory. I still felt helpless and frustrated. Yes, I was involved in the response of the university and stuff, but there wasn't much I could do. And partly that was because we didn't have a model for campus, like how the disease would be transmitted on campus and stuff like that. There wasn't anything that I could say, like, this is what you should do specifically in this building or that building. And that was just frustrating. So I was just like all of you, I was sitting at home teaching my online classes and just being frustrated. There were efforts to model COVID-19 very early on. So one of the most well-known efforts is by the Institute of Health Metrics Evaluation. They still have this website where you can go, and then there's a model that they use to predict disease transmission for a long time. It's relatively simple. It's a deterministic model, again, just like what we use in class almost. But it is only for a large geographic area, let's say for a state. It doesn't have a small scale. And it does assume homogeneous transmission, and it's certainly not individual based. It doesn't take individual people into account. One that's a little bit better is what we call COVASIM, and this is by the Institute of Disease Modeling that's also in Seattle. And that's a network-based model, so it's a little more individual-based, but it basically simulates disease transmission in these networks of people who know each other and interact. So this is more heterogeneous. Actually, the Spokane Regional Health District used this to model disease transmission in the city. It's good for that sort of scale. It's still not the best for a university campus. However, that's what we had available. So when I was teaching disease ecology capstone from home the spring of 2020, I had a group of students who took it upon themselves to use this model to try and model disease transmission on campus. And you see Tiffany, my current grad student, was one of those. And they were basically, at that point, we just had non-pharmaceutical interventions, right? We had social distancing and we had maybe masks and just like closing the school and that's it. And so they were looking at what happens with 50% social distancing versus no social distancing on the campus. And as you can see, there's like a 10-fold decrease in number of cases with social distancing. So that was interesting in itself. Like it doesn't map linearly. But again, this was not quite what we would have wanted. On the other end, people have been developing these physical models, these physics models of flow of respiratory droplets in the air that are quite sophisticated. So that's sort of the other end of the spectrum at really small scale, like within this classroom as I'm speaking, how are particles going in the air? But these are super complicated and computationally intensive. And so typically these are not used beyond a single room. So how do you link these two scales where you have models that are really large scale, state or city, and then you have models that are really small scale, like a room. But what we really need is something in between. And so that's sort of the challenge that I was seeing. And that's sort of what I took upon myself. At that time, we had these ideas about directional flow. If you remember, we had these arrows everywhere in grocery stores and stuff like that. And so the idea was that way you can cut down on how much people come into contact with each other's respiratory transmission or droplets. But we didn't really know if those are working or not. And then we had somewhere, even in the buildings, we had these shields in front of people's desks with sort of the same purpose. But again, the physics models would show that they might be useful, but we didn't have a way to scale it up. That's my phone, sorry. It's a scam. Okay, I was also thinking about students who are still on campus, especially students in the dorms. Like at this time, yes, we were mostly learning from home, but there were students who needed to live somewhere. And so they were living in the dorms and they had to live and do their own stuff. And so I was thinking about what can you do to figure out what would be the best way to limit transmission in those spaces. And I haven't seen any models that would have been at this sort of building level scale. And I'm still looking. And I have had students looking for those and they still haven't found one. So let me know if you see one of those, because I want to see what other people are doing. This was the fall of 2020. And so there was a COVID Innovation Challenge at WSU that I applied for, and even Jenny Pfeiffer helped me with the PR stuff for that. And this was the general idea that I wanted to do. So this is like a grocery store, like imagine it as a grocery store. And these white stuff are the aisles, and the yellow are customers, and the red, no, the circles are customers. The triangles are employees who work in the store and they move around. And the yellow people are susceptible, the red people are infectious, and there's viral particles that come out of infectious people. And when susceptible people get into contact, they can get infected. But people can walk around and all that sort of stuff. And then, you know, some people wear masks. And then at that point, we didn't have vaccination, so that wasn't in the model. So this was sort of my dream that I wanted to make. So that's how this sort of started. So what it ended up being is that something I call COVID Adapt. I wrote it during the winter break of 2020. It's in C++. That's one of those computer languages that people write programs in. It's an individual-based model. So there are these little individuals here, and the model is all about what they are doing and what happens to them, and each one of them has their own stuff happening. It's a stochastic model. I'm going to go into that in a minute, but that generally means it's random, like it's based on probabilities versus equations, like deterministic models would have equations. This doesn't have equations, it has probabilities and events. It's spatial, so it's a grid that it basically runs on. I have this like big grid, and each grid can have a person or not in it, basically. And then I created these maps. This is a map of Pierce Hole, which is circular, which we saw here. So this is Pierce Hole. So that's the salt and pepper shaker just next door. And I can't do a circle on a grid. So I had to basically turn it into a square instead. So I had to just take a piece of, you know, math paper and just sort of figure out how to map it. And the way the map works is that each of these little grid cells can be open in the 4 cardinal directions, like north, south, west, or east. And then they could be either open in the direction or closed. And so if it's closed, then there can be no movement in that direction. And usually it's closed both ways. So you can't have unidirectional, but it's possible to make it only close one way, and then you could do like the directional flow kind of stuff. So I'm only modeling airborne transmission. That's basically what I decided, that I'm not going to get into fomites, so things that are contaminated like this, or droplets. That's too complicated. There's way enough particles with virus that are being able to circulate that it's enough to just model the airborne transmission portion. And then the viral particles I allow to decay. So over time, the viral particles will either die or just drop down to the floor or just go away with a certain time. And in the model currently, there's no ventilation included, but there could be. So that's one of those like future steps, or diffusion between rooms. But again, that can be improved. Okay, so on this map, you see these little dots. Those are the people. And so people can be in 4 different states. They could either be susceptible, which means they can be infected. Previously, that would have meant that they never had COVID. Now it just means that they had COVID such a long time ago that they are not protected anymore. They can still be infected and become infectious. The yellow little dots, those are exposed people. So like there's one here. So exposed doesn't mean just exposed, it also means it's somebody who's infected and will become infectious. So not just like cursorily exposed. And then eventually those people become infectious. That's this little red dot. And so infectious people, they produce enough infectious viral particles to infect others. So, you know, like I was exposed at home by my daughter, but I was vaccinated. And so I probably didn't produce enough virus to become infectious. So I would not be in that infectious category in that sense. And then eventually, I don't have any one of those on the graph, but they would become blue. Those are recovered. And so in this model, at least, those are no longer infectious and cannot be infected anymore. I don't deal with like waning immunity where people eventually become infected. This is at the time scale that's not really relevant at least for now. I don't model disease severity, so the model doesn't really do anything with how sick people get. I'm just assuming if somebody gets sick enough, they would not be in the dorm. They would be moved to the hospital, and then that's it. Again, I don't deal with loss of immunity. I'm only assuming that there's a single strain infecting at a given time, because otherwise it gets really complicated. And at least now, all the parameters are set the same for every individual, but because it's individual based, supposedly you could set them different for individuals. Like some people could become infected easier than others, or produce more virus than others, or feel infectious for longer than others. That's all options. Okay, so how do I deal with viral particles? That's actually quite difficult, because as far as I know, and correct me if I'm wrong, we still don't have an infectious dose for SARS-CoV-2 in numbers of virions. Like we can't say like we have 10 to the something number of viral particles and that's what is required to become infected. I have not seen that paper yet. So what can we do instead? Instead, we use this idea of quanta. So infectious particles are quantified in terms of these quanta. Quanta are basically a made-up unit. That means the amount of infectious particles required to infect 2/3 of susceptible individuals in a space. So this was developed for tuberculosis research back in the 70s. They literally, I think they had bunnies that were infected with TB, and there was one that was infected in a lab, and they put in susceptible ones next to it, and they looked at how many of the susceptible ones get infected, and that was their quanta. So we basically use that. The quanta emitted is estimated from the original SARS-CoV-2 strain at documented infection events. So, there were these events where there was a person on a bus in China. They knew that that person was infectious, and then they looked at how many people on the bus got infected during the trip. And that's how they estimated quanta. And there was a train, I think there was an airplane, the same. So there were several of these events. And there was even that choral practice in Seattle where there were people who were infected and then looked at how many other people got infected. For the other strains, since the original strain, there's evidence to show how much more infectious they are than the original, and then we just use those to basically multiply the quanta that we have for the original. Okay. Oh, and on this graph, the redness that you see, that indicates how much quanta you have in the room. And so, for example, right now in the model, it takes 50 quanta for someone to become infected. And some of these locations have up to 1,000 quanta. So there's a lot of infectious particles there, but the redness shows you how much there is. Okay, so I did incorporate eventually vaccines and masks into the model. So the way I incorporated vaccines is they can reduce the probability of infection for a susceptible individual. That's what I call vaccine efficacy. I know in real life, that's not what we call vaccine efficacy. What we call vaccine efficacy in real life is how much less likely you are to end up in the hospital or dying. But that's irrelevant for this model. So I'm just looking at, are you more protected from getting infected? And I didn't assume that vaccinated individuals would be less likely to infect others. I assumed that if they do get infected, I assume they would just as likely infect others, which is not quite true, but the vaccine is also not great at that. So I also incorporated masks. that reduces the amount of quanta emitted by an infectious person. So, you know, a 95% like N95 mask would cut down the number of viral particles by 95%. And also, the mask also reduces the probability of infection for a susceptible individual by the same percentage. So that's what I assumed. And any individual that is in the model can be designated as vaccinated or not, or masked or not, but that cannot change during the model. That's something I could change. Like I could make it such that somebody can take off their mask and put it back on, but that's not in the model right now. Okay, so I told you it's a stochastic model and event-based. So I want to give you a little more detail on that. So it's called the Gillespie method that is used. Basically, what I do is I randomly choose a time to the next event that happens in the simulation based on the total probability of any event occurring to any individual. And some of those events are movement. People can move, and for now it's random. People are just gas particles in this model, which is not quite true in any direction. Susceptible people can become infected, and that's a function of the local quanta. If the quanta is higher than, say, 50, then they are very likely to become infected, and if it's less than 50, then they don't. Exposed people can become infectious as a function of the time since becoming infected. So that's where I incorporate the incubation period. So after, let's say, 5 days or 3 days, it's very likely that somebody becomes infectious. Before that time would pass, it's not likely. And then infectious people recover, but that's again a function of the time when they became infectious. So, you know, it's 5 days or 10 days, however long they are infectious. After that time, they are more likely to recover. And these are all logistic functions that provide probabilities for these events. And then I choose an individual to whom the next event will occur, either movement or any of those other stuff that could occur, as a function of the proportion of the probabilities of events for that individual versus everyone else. And then I randomly choose the event that happens to that person based on the relative probabilities of all those events that could happen to that person. So that's basically how the Gillespie method works. Okay, so there are some important parameters in this model that I had to get numbers for. So one of them was the amount of quanta required to become infected, the average incubation period, the average infectious period, the rate at which the viral particles decay, the vaccine efficacy to reduce probability of infection, the amount of quanta emitted per minute per person, and then the efficacy of masks to reduce the quanta emitted and the probability of infection. So these were like parameters that you can change in the model, and then things change. Okay, so I built this model during that winter break, and then I needed students to work with to help me. So I found Roxanne McPack, who is going to be a grad student from the fall with Dr. Castillo, as well as Jana Murota, who were willing to help me with this. First of all, they did a literature review looking for similar models, because I was thinking if somebody already has this, why would I spend the time? But they didn't find anything completely like that. The one that they found that's closest was this paper by these authors on modeling aerosol transmission. So these people actually work at a company that does like chemical hazard research for like factories and stuff. And they have this model called FATE that is basically a model to look at chemical flow within a building. Like, you know, if there's a spill or like an explosion and there's like hazardous chemicals everywhere, and how fast would that circulate in the building? And they wrote a paper where they basically said, well, let's assume people are just like a furnace. And furnaces take in air and then they exhale byproducts. And in this case, that would be people taking in viral particles, getting infected, and then exhaling viral particles. And let's see how that would then circulate within a building. So that is close to what I was doing, but not quite the same. They weren't allowing people to move around or really meet with each other or change places, because furnaces don't do that usually. But what they had that I didn't have was a way to like look at flow between rooms. Like, see, this is a person, and then they exhale something, and then there's airflow to this room, and then even into the ducts, and then like between the AC system and stuff like that. So I tried to sort of develop a connection with them and work together. It sort of fell apart, but I want to go back to them and sort of reinvigorate that. You know, everything is proprietary, of course, what they do, so it's not simple. Okay, so they found this model for me, the students, and then they did a big literature review trying to estimate all the parameters that I need for my model. Like, what is the incubation period of COVID-19? How long are people infectious? And then how much quantity they emit and all that sort of stuff. And then they also created maps for the first and the second floor of Pierce Hall. And that's what you saw on the previous picture. Okay, so that's where I was in winter of 2021. At that point, I had this model that I wrote that was in C++. It wasn't very user-friendly. I couldn't just give it to a student and say, hey, run some models. You literally had to change parameters in the program. There was not even a command line thing where you can change the parameters. So I needed something better. There was no graphical user interface. The maps were basically created by hand. So what I did is I connected with Brian Davenport, who does like our community engagement. And he knew somebody else at Whitworth who did the same thing. And then they knew the computer science professor who was teaching their senior capstone. And they needed some projects. And so our program became one of their projects. And what was really nice is that they created a graphical user interface. That was their problem, their project, to help me make a graphical user interface. They did that in Python, which is a different programming language that I never used. I'm sort of trying to get used to it. But what was really nice is that it was a collaboration between Eastern students and Whitworth students. Like, it was all on Zoom, of course. But I was able to bring together Roxanne and Jana with the 3 computer science students from Whitworth and have discussions between them on what they can do and if that's going to work for the biology. It was a nice thing. Basically, what this Python program does, besides being more visual, is it creates copies of the program in folders, and then it runs everything in that folder, the original program, and then it gives you graphs. And you can also use it to make a video of the simulation if you want to. So let me show you that, because I want to do a little demonstration of how that works. So here's the program itself. Is it visible on Zoom? Okay. So I just give a little name to the new project. I should go back and make a completely new one. Okay, and then there's a button that says settings, and then this is where you can change all the different parameters. And some of these are not that important, but like this is how much quanta is needed to infect someone. This is in minutes, how long somebody is in the incubation period. That's 5 days in minutes. That's 10 days for the infectious period in minutes. This is the decay rate, vaccine efficacy. This is how much quanta is being emitted. This is the mask efficacy. And then you can also supply how many people you want to begin in a certain category, like how many people you want to begin infectious, unmasked, vaccinated, susceptible, vaccinated, unmasked, or unvaccinated, unmasked, and also how many masked people you want to have. And then this is just the size of the map. And then this is how long you want the simulation to go. It's in minutes. So 30,000 minutes is about 3 weeks or so. So again, not quite realistic. It's as if people in the dorm would be locked in for 3 weeks on the same floor. I wouldn't suggest that, but that's what the simulation. Okay, so I'm not going to run it for 3 weeks because it takes quite a long, but it's very quick for just 300 minutes. So when I click on Save Settings, I can just click on Run Simulation. Then it's running there in the background in this like command line area. And then it makes these graphs. So now it's back. So this is the total number of virus as it was be accumulating in the air from the 4 infectious people that we had. This is the mean amount of virus, of course, that's similar to the total. This is incidence. So incidence is just like how many people you have currently who are infectious. And so because it was only 300 minutes, there were no new infections. So it's only those original 4. And then prevalence would be altogether how many people have become infected over time, like that sort of stuff. And then if you want to have a video output, you can click on export. And then it makes a video. And while that's being done, I'm gonna show you where it puts everything. So it has its own folder, and then within that, there's a saves folder. And within that, it puts every simulation in its own different folder. And so that was the name that we assigned. And then here's all the graphs that we had. And then it makes that one video that it's working with right now. So it's kind of user-friendly. It's maybe not the user-friendliest, especially with where the files are being stored. That's a little hard to find. It's buried wherever the program is being installed. So I'm working on trying to make that a little bit easier to find, but it's better than the command line version that I had originally. There were also plans for the computer science students to make a map creator where somebody could like point and click and make a map. That didn't quite work out in the end. That was, they only had so much time for the project, and that's just how it works. So now it's finished with that. And then in the end, you get this MP4 file that is showing you what happens in the simulation. So you can see how people are moving around, again, sort of randomly. And I can put this maybe on a loop. So you can see how they are moving around randomly, and they are contaminating some spaces where you have the infectious people. So the grids are broken up into regions, what I call regions. So one room is generally a region. So if there's one grid being contaminated, it averages out in the room, just sort of evens out. That's a little bit trickier on a circular. This is originally a circular hallway in the Salt and Pepper Shaker building, but here it's a square. So here I had to make some decisions on like, okay, this is one region, that's one region, that's another region, and so forth. And so whenever people wander into an area where there's somebody infectious, like there was one person here who turned yellow because they were originally green, as you see it here. And then because there was so much viral particles in the air there, they became infected. So now they are exposed. And then eventually, if we would run it long enough, you would see that person turning infectious and then starting to infect others. So that's basically how the program works. Okay, so, Any questions at this point about the model?
I was curious about one thing, like in the settings, bring up the COVID attack.
Yeah.
So I'm a little bit curious. So what constitutes, like, for instance, number susceptible vaccinated? Is that like individuals who've been vaccinated but not naturally infected?
Yes.
Okay.
Yeah. So that this would be like I was like, I don't know, last summer. Like I haven't been yet gotten COVID, but I was vaccinated, and so vaccinated is tied with the vaccine efficacy, right? So that's at 0.8. So that just means whatever vaccination status you have that gives you 0.8 efficacy to protect you from getting infected. And that's so I didn't use any like actual vaccine data. This might have been like the efficacy of the vaccine against Delta after 2 doses, because this was all done like last year before we had the 3 doses. That's what I remember. Did that answer your question?
Yeah. The other thing I saw it because I hadn't noticed first time whether or not there was a susceptible unvaccinated.
Yes.
Setting also, but I see that.
Yes. So there's susceptible vaccinated, susceptible unvaccinated, and of course you can play around it. You know how many you have of each, depending on what you see happening on the ground.
Considered putting in like a parameter for number of doses?
Yes, and then I didn't because yeah, it just gets too complicated.
Would they have to calculate that for every individual, like kind of stochastically, whether or not
Yeah.
they got?
I mean, you could for sure. Like you could have a distribution from which it pulls a random number. But yeah, I did not do that. Yeah.
My question is related to the vaccine efficacy.
Uh-huh.
So here you've got a set to 80%, so that would be 20% susceptible. Is that rolled on every encounter? Or is
Yes.
it previously established where 80% won't ever be infected if they're exposed and 20% will always be infected if they're exposed?
So it's not the second, because then effectively you would move susceptible people to recovered. That would be like sterilizing immunity. And then they could not get infected ever. So it's the first one there. On every chance when they could get infected, the probability of them becoming infected is multiplied by 1 minus 0.8. And so, yeah, it's that kind of vaccine efficacy. And whether or not that's appropriate biologically, I'm not sure. I don't think any of us really knows, but yeah. Like which one is it really? It's probably more of this than the sterilizing immunity, just based on what we know. Yeah. Uh-huh.
Thinking back to the symbolizer,
Mhm.
the different tiers you've broken the high category into the exposed versus.
Yes. So this is an SEIR model in that sense. So susceptible, exposed, infectious, recovered.
So the effect of that, so do exposed individuals, do they always become infectious?
Yes.
Okay. So is the effect of that just a kind of produce a delay between exposure and?
Yeah, it does produce a delay, and there's some other dynamical consequences which I'm not quite current on. Maybe Jenny knows, I don't know, but yeah, there's other differences, especially in terms of the equilibrium and like what, I think with an SIR model, it's harder to get a stable equilibrium where there's always infection going around, whereas with an SEIR, you could, like where it's just a constant level of disease, which is, I mean, that's where we're sort of going. Yeah, okay. Okay, so now that you know what the model is and how it works, I can show you what we did with it afterwards. And I need to change that, okay. So during the senior capstone class last spring, we already had this graphical user interface. That was the whole point, so that I can give it to the students so they can use it in the class. And so Raya Horton, who was one of the students in the class, along with Roxanne and Diana, they used COVID Adapt. And so what they did is they came up with these different scenarios. Each of them had 16 individuals. The first one was just control, no masking, no vaccination. Second one had 75% of these 16 individuals masking. The third one had 75% vaccinated. The fourth one had both. And then the fifth one had everybody masking. And then just looked at what happens with prevalence over time. She ran the model 25 times for each of those 5 scenarios for the 3-week time span of the simulation. And this is what they got. So this red and the purple, that's scenario 1 and 3. So the control, and then there was 75% vaccination. That's when they had the most, like everybody got infected, basically, 16 out of 16 overall. Whereas when there was masking, so scenario 2, that's this blue one, and then scenario 4, when both masking and vaccination, there were much less infection. So just showing that, yes, masking really does work. And then when 100% of the people were masking and 75% vaccinated, that's when you had the lowest infection. And the reason why you can have non-integer values here is because this is the average over 25 simulations. So it just sort of averages out. So this doesn't mean that the vaccine is not effective. Even based on these assumptions, it just means that it's not effective in reducing transmission. Like it's still effective in keeping people out of the hospital and dying. It's just in the model, I mean, I assume that there's not much effectiveness in reducing transmission. So that's not surprising in that sense. What is surprising to me a little bit is how effective masks are. And you'll see that in the next slide more. And that's because vaccination only reduces the probability of getting infected. So then Roxanne actually continued on. I got a faculty research grant last year to work on this model. And I sort of started early, but I still had it. And she was the student worker with me during last summer. And she did a lot of different things. For example, she did another literature review. It was last summer when we had Delta. So we had to update everything, all the parameters for Delta. So we did that and then looked at what the differences are. And then she ran another batch of simulations with 12 different scenarios. So each of these letters are different scenarios with 40 people in that floor of the dorm. So double occupancy, because that's what we were hearing, is that there's going to be double occupancy in the rooms for, fall of 2021. And then she ran 20 simulations for each of those, and then used Poisson regression to compare the prevalence. So how many people got infected overall at the end of 3 weeks. And then this graph summarizes her results. So you can see here, this is a situation when the infectious person is unmasked, nobody is masked, and only half of the people are vaccinated. About 34 or so people out of 40 get infected in 3 weeks. In this situation, half of the people are masking, but still only half of them are vaccinated, but the infectious person is still not masked. So there's a little decrease in prevalence, but not much. If everybody is masking, now we have much less prevalence, like half the prevalence. But here the infectious person is still not masked, only the susceptible people. So it protects them to some degree, but still half of the people get infected. And then compare that to this one. So these are the scenarios where the infectious person themselves is masked. There's way less infection, like 15 or 20 or 15, not 0. We can't eliminate infection altogether, but we can certainly cut it down a lot just by masking. And then when we compare these two parts, So here, half of the people are vaccinated. Here, everybody is vaccinated. There doesn't seem to be a huge difference. Again, this is not because the vaccine would not be useful. It's because this is about transmission, not severity. And the vaccine doesn't really block transmission. So this was interesting. And whether the infectious person is masked, that seemed to be the most important. But then again, you don't know who's infectious. Even the person who is infectious might not know that they are infectious. So that's why it made sense for everybody to be masked, because you could be the one who's infectious. When you think about it, the big difference from the masking, at least that's how I think about it, it comes from the 95% protection both ways. It's cumulative. It's 95% coming out that is cut down, and then 95% of those particles are cut down when people are breathing in the air. That's multiplicative. That's what makes masking so effective if everybody wears masks. Okay, so what we also did, and what Roxanne did, is we wrote this up in a preprint. So for those of you who don't know, preprints are not peer-reviewed articles. Those are, it's basically a step before you would submit a research to a peer-reviewed publication. But it's a place to put something that is time sensitive and you want people to see it. And also if you want to claim a stake on something that you did it first, that's also a timestamp that I had it here. So we were able to post this preprint with Roxanne as the first author, summarizing those results with that title: masking reduces but doesn't eliminate COVID infection. And beyond that, we also made this video that I would like to show you. So here you see the two simulations side by side. And in one of these simulations, everybody is masked. And in the other simulation, nobody is masked. And there's only a single infectious individual. And this was made recently, like this fall. And so, so here, there's some details. So 8 people start out as infectious. So this is like, I was thinking like Omicron surge, like a lot of infection going around. The rest are susceptible. 29 of the susceptible people are fully vaccinated because we had higher vaccination rates by this fall, and 2 are not. And so those are the starting conditions. And I'm not gonna tell you which side has people masking, but you'll just have to see for yourself. I had to calibrate the colors so that the quanta is the same, like the scale of the quanta is the same on the 2 sides. So which one do you think has people masking? Yeah, the right-hand side, of course. So when people are not masking, there's all this quanta being. And then you see a lot more people who are red or yellow, a lot more infection going on. And here, there's still people who are susceptible. Like even though there's 8 infectious people on both sides, just having the masks protects people way more. So you can do these things. Okay. So what happened during the fall of 2021? I gotta tell you, I was super nervous coming back to teach in person in the fall, especially running my simulations. It's like, this is not gonna end well. But I was surprised. Partly there were less people on campus, as we know. There was a decent vaccination rate incoming, was fairly good mask compliance. Kudos to the students and everyone else. Most people had their masks on during the fall and winter. And there was testing and quarantine with the rapid testing at Tawanka and all that. So some people were being filtered out who were infectious. Then, of course, we got hit with Omicron. So this is the happy curve on campus. Like this was the fall, and then that was Omicron. So yeah, that was, of course, different. But then again, my model is not perfect. Like maybe my model just overestimated the amount of transmission that would occur on campus. Maybe it's not as transmissible as I was thinking, and it's not as bad. But what I also remarked is that human behavior is the most important. Like I remember during the fall quarter, students asking me like, Dr. Magori, what's going to happen? Are we going to have a big outbreak? I'm like, I don't know. It depends on you. Like, it depends on what people are doing, right? I mean, we have the tools, we have the vaccines, we have masks, we have tests, but then we can't really control people. And so I can't tell. And I put Francis Collins' name there because he's the NIH director who's just retiring, and he was there for like 30 years. And in an interview, he made this comment that we should have invested more funding into behavioral science and public health communication, because now we realize we can have the best tools available, and if people choose not to use them, it's all for nothing. And so that's sort of where I'm going as well. Where can you find COVID Adapt? So there's actually a website that has the program available if you want to play around with it. There's a Windows version that you can just download, and it has an installer like any other commercial program that, you know, goes through the installation steps and puts it on your desktop, and then you can play around with it. It's a little tricky to find where the files are being saved, but that's the only part. I also made a Mac version that I'm not a Mac person, so it might not work quite completely as well, but I tried. And then Roxanne, she also put together a user guide and the tutorial that has like a quick use tutorial that has all the details on how everything works. With like, Roxanne is great. So she like put screenshots in there on what you need to click when, if you want to use it, and that's all available through here. And then of course there's the preprint. And I decided to put this program under the Creative Commons BY-NC SA license. That basically means I don't want to sell this. I just want people to use this. And anybody can copy, change, distribute this. You can send it to other people, provided that it remains under the same license. Like, I don't want other people to make money off of it. And of course, I'd like to be credited that I made it originally, even if it's being changed. And it even allows for somebody to use it as part of a commercial service where they like go someplace and offer their services using this program. So that's sort of the license part of it. So what are the next steps and future directions? I have a lot of plans to use this, but of course it gets rapidly out of date, right? Like every information changes all the time on COVID. Like now we don't even have Omicron, we have BA2 and some other sub-strains of it. So I had a student, Jesse Grove, who did a literature review with me as a directed study during winter quarter to try to estimate the parameters for Omicron. So we can update it from Delta to Omicron. But now we might have some other stuff. And so he will be running some simulations with those parameters to see what happens. I mean, we know kind of what happens. Omicron has a shorter incubation period and you're infectious for a shorter period. So it's gonna just spread faster. And it is more transmissible. So the quanta rate is higher. So it will just burn through the population quicker. And that's exactly what happened actually. But still, it would be good to see that in the model. I need to develop more floor plans. I can't just have Pierce Hall. That's just one building on campus. I'd like to have floor plans for every single building on campus, but that takes a lot of effort and time. And I also want to connect different floors of the same building so that my little individual people can move between different floors. That's like a computational thing. I also received another faculty research grant for this summer and next year to keep working on this. First of all, there's a treasure trove of data that Student Health Center collected over last year of contact tracing, of all the people who went for testing, and then they asked them, who did you meet and what were you doing, and then follow them up and see who among those got infected. I want to get access to that data. I don't know how hard it's going to be, like putting in an IRB and all of that sort of stuff, because I want to learn what were the situations in which people got infected and what are the situations when they didn't. And then I want to use that to make my model better. I actually want to survey actual students on their behavior because I know they are not gas particles. So I want to know, like, when do people get up in the dorm, and do they go to the bathroom first, or do they first go over to their friend, or what is their like movement patterns? Like, do they come back after classes or during classes or for lunch break, or when are they having parties and how many people are attending the parties? And because that's all needed to really know what's happening in there, which then affects how disease is being transmitted. So I'm not a sociologist. You need a sociologist for that, or a psychologist. So I'm gonna have to find some sociologist or psychologist to go and develop those surveys and administer them so I can get the data and use that. There have actually been efforts nationally. I found this like institute that did this workshop where they were trying to bring together sociologists and disease modelers and other people to try and figure this out, because it's like two disciplines that haven't really worked together that much, but we really need to. And then I want to use that to validate and improve the model so that I can trust what comes out of it. I also want to make COVID-Adapt more user-friendly and easier to use than even it is, because I want to make it more widely available. I think it could be great to use in classrooms. Like, I'm imagining a high school teacher assigning their students to make a map of their high school and then putting it into the model and then running simulations on, like, okay, what would happen if one of you came in with COVID? How quickly would everybody get infected, given that we're no longer wearing masks and all that sort of stuff. But for that, I need to develop lesson plans, because that's what high school teachers work with, and then maybe try and introduce it to them and then see. And then finally, we're all fed up with COVID. We don't want to hear about COVID anymore. But there are other diseases that are still around and will be around, and COVID will also be around. This model could be easily tweaked for other airborne transmissible diseases like influenza or measles or TB or any other kind of stuff that transmits in respiratory particles. We just need to know what those parameters are. And so I could imagine even renaming it to something not COVID to make it more widely available. And then people could use it for all these other things, not just COVID. So that's where I need help. And so if anybody is interested in helping me with any of that, students or faculty or anyone else, let me know. And that's basically it. Before I open it up for questions, I want to let you know that the Climate March is happening next Friday in Spokane. 350 Spokane, 353spokane.org is organizing it. And I am now the advisor of Eco Eagles, which is a student club that's going to that. But the more people we can get to show up at the climate march, the better. I'm not sure if I'm exactly correct, but I suspect that our crazy weather can be attributed to climate change because it happens because the jet stream was pushed down south because it's unstable due to climate change. Although I'm not a climatologist, that might be incorrect. Okay, thank you. Looking forward to your feedback.
We talked about adding scheduling and individuals in the model. I'd also really love to see in terms of masking degree of compliance. So what is the probability of a person, and how frequently and how long do people mask during time periods? So a masked person could spontaneously become unmasked, set that parameter. There was something else I was thinking of, again, related to behavior. With arrows, traffic flow. So you could put traffic flow going in with that scheduling and then see what is the minimum number of compliant individuals necessary for that to provide an income. Like 90% of people, it still works, just drop down to 80% and things not having it.
Yeah, and the masking is totally possible because it's individual based. Every single individual is tracked in the model separately, and literally each of these are called objects. So C++ is what's called object-oriented language. So it works with these objects. And each of those individuals have basically a flag that says masked or not masked. So far I chose not to mess with that, not to change that during the simulation, but there could be an event that is taking mask off or putting mask back on. And that could even be dependent on what other individuals in the vicinity are doing. Like, think about peer pressure. Like you go into a classroom and no one's wearing a mask. You might take it off because I feel weird being the only one. Or, as faculty, we take our mask off when we are at the lectern. So yeah, all of that could be possible. And then in terms of traffic flow, so there's that thing where I can close a door basically one way, close a wall one way, and then it's impossible to go that way. But it also could be done where there's a preferential direction, like there's a higher probability of going in a certain direction than different directions. And that can be based on the grid location itself in the model. And there's also a possibility, so there are other physical models that simulate just movement of people. I don't know if any of you seen those where they simulate how people are, what happens when there's a stampede at a concert. Like there's something happens and everybody starts running for the door and there's like a column in the middle and people are getting stuck. And there are computational models to simulate how people are moving in those directions. There could be potentially a way to combine that sort of thing into this, where like, for example, with the scheduling, people are probably moving out of the dorm at 7:50 going to class, right? So there's a directional flow just out of the dorm. And that can be incorporated into the model by changing the probability of moving one direction or another. And that will sort of create directional flows by emergent behavior in that sense. Like individually, they all do different things, but together it will create a flow. Yeah, that's a great idea. Yeah, thanks.
So it seems like now that we're out of the lockdown period, that the most unrealistic part of the model is that the people, the dorm residents, real life are sort of going and interacting with other
Yes.
people. I realize you want to keep the focus of the model onto the building scale, but I wonder if you could sort of incorporate that sort of interaction with other people by having sort of, I guess they would be within the view of the model, basically spontaneous infections. which would be someone who exposed to someone, while they were in class and then came back to the farm.
Yeah, that's certainly possible. And I've been thinking about the related problem of people going on and off campus. Like, you take the bus, go home, and then in the morning you come back. So you like disappear from campus. I could make it such that individuals disappear from the model for a time. They just don't have a location. And while they are off campus, there could still be stuff happening to them, like infection, because they would still be in the model, except they wouldn't have a physical location on the map. Yeah, these are all like great ideas that are like going on a to-do list of like, these are things to incorporate.
I can remember early on when you're modeling with like the individual who's infected. How is it that you're modeling like the quanta, like distance-wise? Like, is it that like do you have like a particular radius that's like another quanta?
That's a good question.
Like this, because I always had that, or that's one thing that always pops in my head was when we talk about like unidirectional traffic, where like, just because people are all moving in the same direction, say if you've got an infectious person, they're essentially making a cloud of infectious particles, and people are just walking into that. Like, does the unidirectional movement provide any benefit? Like stuff like that. I didn't know if like in the model that kind of distance or like radial area was already modeled, or if it's literally just like, if the dots physically bump into each other, then like, oh, now you're infected.
So that's a great question, and it reminds me that I forgot to tell you an important detail. Each of these grid cells is 2 by 2 meters. That's high through the grid. Looking at the map of the dorm and knowing like how long those walls were, and then trying to map them to be a square, but still keeping the areas at least somewhat similar. Like, maybe not on this one, but I have another map where I actually have like square footage. So each of those grid cells are 2 by 2. Originally I had 6 by 6 because, the 6 meter distance, like, the 6 feet, which is, how much is 6 feet? Yeah, okay, so that's fine. Okay, that's fine. So that's basically the 6 by 6 feet little square. And so each of these little grid cells, they can't have more than one person. At least I don't allow it currently to have more than one person. Technically, there could be. And so infection doesn't occur because they touch. It's because they go into an area that has been contaminated by someone who was infectious, who was there before. And then also I have these regions where, even that infectious person up there, that person is technically only contaminating that little 6 by 6, but for a lack of a better method, I just spread out the virus instantaneously within the same room. And there should be a better way to do that. And that's what that company does really well, the Fate model. But then again, their stuff is proprietary, and so I wasn't able to really link up with them. But yeah, that could be improved for sure.
Yeah, I was thinking that it wasn't so.
Yeah. Cool. Ellen?
How little air movement control was closer. COVID, we talked about people moving directionally, but I was wondering if your model, the state model, either had the capacity to include control of air movement.
Yeah, and that's again an excellent question. The Fate model for sure. That's basically their bread and butter. That they model how the HVAC system works and pulls out air and how quickly it replaces the air in a room and that sort of stuff. I myself disappointed on how little of that we have been doing during the pandemic. Like just in my home, we bought these air purifiers, but I haven't seen those widely deployed. And I know some schools have some air purifiers, but not much. And then just recently, I was reading that there's more support from the federal government I think there's a new set of guidelines that they published on how to make air cleaner, basically, in public buildings. And some of that is the HVAC, air purifier. Some of that is literally just opening the window, which is just like culturally, it's like foreign at this point, I think, for most people. I mean, most of our public buildings don't even have windows you can open. So maybe some still do, and there it's a good idea. But yes, certainly that would be nice to incorporate. So that would partly affect the viral decay rate. So an easy way to incorporate it is just increase the viral decay rate. Hey, there's just virus clears out quicker. And then another way would be the sort of fate model kind of thing, where there is actually a diffusion of viral particles in some direction, hopefully to outside of the building, and then that would reduce the quanta in the place. Yeah. Any other questions? Do you guys see this as something useful? That's my question. Okay, then I will keep working on it. Okay, cool. Thank you.